So we're going to talk about biceps tenodesis versus biceps tenotomy. So specifically, what do we do? Where do we do it? So if we look at, again, this is our ball and our socket joint. Sorry, this is the rotator cuff up here. This is the biceps coming in here. So that biceps gets damaged, and we have to figure out what we're going to do with the biceps. So the first thing is we have to decide if you're 15 years old and you're a baseball pitcher, then that biceps really needs to be where the biceps is. And so we will do our best to keep the biceps in its anatomical position, which means where God put it to begin with, right? And so when that's the situation in a younger, really younger, like 20 something below, then we'll put a little anchor here and we'll just fix it there. And that's okay. And that's actually the most natural position for it to be in. The problem is when you get to be my age or older in our 40s, 50s, 60s, if we have this problem plus a rotator cuff tear, if we try to fix the biceps back down where it naturally is, we're going to get stiff. High probability we're going to get stiff. And because we don't need that biceps attachment there for most of our normal daily activities, it's okay to let that biceps go. So the biceps can either be released here, okay, and it gets released, and again, it comes down here, and it gets stuck in this groove. It's a tunnel the tendon is in, and so this part of the tendon is a little bit thicker than this part of the tendon, so it essentially gets wedged there, and then it'll heal there. And for a lot of people, that's fine. It's gonna heal there. You're gonna have maybe a little bit of cramping in the biceps, maybe a little bit of deformity or change in shape of the biceps compared one to the other, and that may or may not be important. Again, important thing for the rotator cuff surgeon, the shoulder surgeon, to talk with you about what you might or might not have. So that's the simplest thing, right? You just release it. That's called a biceps tenotomy. Tenotomy just means you cut the tendon, it comes down here and attaches, and it reattaches here, heals in there. So that's the first thing. So if we worry a little bit about maybe the shape or the cramping, so more active, then we may consider doing something different, which would be a biceps tenodesis. Tenodesis means reattaching it somewhere else. So the tenodesis, we can reattach the tenodesis right next to the rotator cuff up here, or we can attach the biceps down here, or we can attach the biceps down here lower. So a lot has to do with the surgeon's preference as well as somewhat with the patient. So I'll tell you my thought process on it is if we have a biceps, or we're going to tenodesis, we have a big rotator cuff tear. Well, we already have the tear, we're already working here, so it's very easy to add the biceps tenodesis here. So we'll make that and repair it there. If the rotator cuff is not torn, well then it's a little bit harder, again from my perspective, a little bit harder to get to this spot. And so what I'll do is I'll make a little incision right about here, about this long, go in there and find the biceps, retension, we just kind of pull it up to the proper tension and reattach it here. And then lastly, if you're having a really bad diseased biceps tendon, which means the biceps tendon is not good all the way through here, then we'll go below, which is lower, it's called a subpectoralis. We'll go lower where the muscle of the biceps and the tendon of the biceps combined, where they come together, and we'll do a biceps tenodesis down here. It's a little bit bigger procedure, but it may be more stable if you have a really bad biceps throughout the whole thing. So in summary, biceps tenotomy, biceps here, which would be arthroscopically, so through the little poke holes, open biceps suprapec, subpec, and the pec is the muscle that comes across, that's your chest muscle, right? So either you do it right above the pec or right below the pec, and it just depends on what seems to be the right thing to do.